Hello everybody and welcome to the Thursday edition of Video Clips, and today we're going to talk about breast cancer and mammography. And over the last few years that I've been doing these video clips, I've done many segments on this issue, and the reason why I keep doing segments on this issue is that there are so many people, millions, hundreds of millions of people who've been brainwashed into thinking that mammography is a good idea. And whether or not it is for an individual person is for that person to decide, but the story is always very one-sided in a doctor's office. I would venture a guess that most of the doctors who are making the recommendation to get a mammogram have not read all of the information that I've been giving you access to through these video clips. So the first study I want to cover is an interesting way of looking at the validity of mammography. It was a review of autopsy studies, ductal carcinoma in situ and breast cancer precursors, and the researchers found that they're common in women who were not diagnosed during their lifetime. In other words, a woman's medical history includes no breast cancer, but on autopsy they find cancer. The review was large. It included 13 studies conducted in 10 different countries and published between 1948 and 2010, and a total of 2,363 autopsies. The authors state that a compelling reason for conducting the review was to provide more accurate data concerning the benefits and risks of mammography. While the potential for finding an early-stage cancer that might become aggressive is a benefit, risks include overdiagnosis due to the detection of cancer which progresses very slowly or not at all. Autopsy studies can be used to estimate the prevalence of incidental cancer and precancerous lesions in people who aren't diagnosed during their lifetime, which can then provide a much better indication of the prevalence of overdiagnosis and overtreatment. Well, the first thing that the researchers discovered was the more thorough the examination during autopsy, the more likely something like ductal carcinoma in situ or other precursors were to be found. The odds of finding in situ cancer were 127 times higher, and for atypical hyperplasia, they were 21 times higher when 20 or more sections were examined than when fewer than 20 sections were looked at. Now, what this really means, the harder you look for cancer, the more cancer you find. This is important because today's screening programs are looking harder for cancer than ever before. The development of more sensitive diagnostic tools has resulted in more detection of more what are called indolent cancers. They really shouldn't even be called cancers. And I'm talking about things like atypical ductal and atypical lobular hyperplasia and ductal and lobular carcinoma in situ. In fact, about 85% of in situ conditions are detected during population screening, not because any symptoms or palpable tumors developed. By the way, this idea of not calling these things cancer, I'm not the only person talking about it. One of the most well-known breast cancer surgeons in the world who lives in San Francisco has talked about this, and there's an article on this topic in the Health Freaks Library if you want to check it out. Well, in addition to all of this, the medical profession continues to recommend screening for women age 70 and older. And so, and this is a population where you're much more likely to find abnormalities, but they may not make any difference in health outcomes. So more and better screening results in more diagnoses, but not necessarily in better outcomes. Well, how do we know that we're not getting better outcomes? Well, according to the authors, the prevalence of breast cancer in 1975 to 1977 prior to screening was 9.4%, or 1 in 10.6 women. After mammography was introduced in 1987, the prevalence increased to 12.5%, or 1 in 8 women. But here's the thing. The death rate from breast cancer has not significantly decreased. The authors state that the reason is that between 24 and 40% of screening detected invasive cancers are likely overdiagnosed. The reality is that mammography is diagnosing what are called these indolent pseudo-cancers, is what Dr. Gilbert Welch calls them, that women are better off not knowing about, and it's not reducing the death rate from the aggressive and advanced cancers that kill women. They're not getting caught by mammography. According to the authors, this is not going to change much. If anything, it's going to get worse. And one of the reasons is that the technology is getting better. And we always think better, newer is a better thing. Well, not necessarily. If the problem is we're finding a lot of stuff that women would be better off not knowing about, finding more of it is not the answer to the problem. So digital mammography and that sort of thing, there are several different technologies that are being used now to find things at even earlier stages. The other thing is there are much more aggressive biopsy methods and sampling, which will inflate the overdiagnosis numbers even more. They also point out that the consequences of overdiagnosis and overtreatment is much greater for women in their 70s and older than it is for younger women. They conclude by recommending that policymakers, researchers, clinicians, and women who are told to have screening should be made aware of these issues so that women can make more informed choices. Gosh, that sounds like something I would say. And not necessarily undergo treatment for conditions that are best undetected and left alone. Amen to that. Now, related to that, and I found this article the same week that I found the one I just talked about, a new study shows that the use of screening mammography has little effect on breast cancer mortality, but instead increases the risk of overdiagnosis, same as this study here. Now, this one was conducted in the Netherlands, where since 1989, women between the ages of 50 and 69 have been encouraged to be screened every 2 years. In 1997, screening was extended to include women between the ages of 70 and 75. The problem these researchers were talking about, we keep expanding the age range for mammography. And then digital mammography was introduced in 2006. All of these things represented to be advances in breast cancer screening to save women's lives. Philippe Attier and his researchers tracked women who were screened between 1989 and 2012 and determined that the incidence of stage 2 to 4 breast cancer in women 50 years of age and older was 168 per 100,000 in 1989 and 166 per 100,000 in 2012. So the researchers reported that screening reduces the death rate between 1 and 5% while increasing the risk of overdiagnosis and overtreatment by 32%. So you get a small decrease in the risk of something bad happening and a 32% increase in the risk of something bad happening. Furthermore, the introduction of digital mammography and recommendation to screen women between the ages of 70 and 75 years has contributed to overdiagnosis rather than reduction in death rate. In fact, women 70 years of age and older were 2 times more likely to be overdiagnosed than women aged 50 to 69. One of the reasons for this is that while some of us are fortunate to age gracefully, I'm trying to do that myself, there's no question that I'm 61 years old. If you go poking and prodding around, I'm sure you can find something wrong with me. The question is, do I benefit from knowing about it at this age, or is it even something that anybody at any age should worry about? Well, according to Attier, the lead researcher, quote, "These observations are in line with other data showing that the replacement of film-based mammography by digital mammography has substantially increased the burden of in situ breast tumors without decreasing the rates of interval cancers." Interval cancers, by the way, if you're not familiar with that term, are tumors that develop in between mammograms, which are much more likely to be deadly. Attier went on to say, "It strongly suggests that the advent of digital technologies has probably worsened the overdiagnosis problem without clear evidence for improvements in the ability of screening to curb the risk of breast cancer death." Dr. Gilbert Welch, in one of his books, and he's written several that are just terrific, he's a medical doctor, talks about, we always think new is better. He said new is not necessarily better. New is only better after it's not new anymore and you've had a chance to see what really happens when it's used in the marketplace, and this is a good example. Attier goes on to say, "The main purpose of cancer screening is to catch the cancer at an early stage before it becomes metastatic disease. If screening works, then you must observe a decrease in incidence of the burden of advanced, poor prognosis cancer in the population. While we've seen decreases in the incidence rate of advanced cervical and colorectal cancer, the same thing has not been true for breast cancer." In other words, we're finding lots of stuff we don't want to know about. We're not finding the stuff that can kill you. Attier also says that he expected that mammography would be effective, but the failure of mammography in reducing the death rate, quote, "is something that is being observed not just in the Netherlands, but in all countries where there's a lot of screening, including the United States." I think we're the champions at screening here. We find more and more things to screen for, we do the screening more often, and we extend it to later and later ages. Gilbert Welch, as I mentioned, has published research showing similar findings and says, quote, "An important message is you don't solve the problem by throwing more technology at it. Adding an ultrasound, adding an MRI, adding digital mammography, this only makes the problem of overdiagnosis worse. The harder you look for this stuff, the more likely you are going to get into the overdiagnosis problem," what I said earlier. He says, "We've overstated its benefits and understated its harms. It can lead a woman to be treated for breast cancer who would otherwise never need to know about it. Welch also commented on cancer screening in general, stating, when you start getting older, you don't want to be doing any kind of cancer screening. It creates more problems than it solves. It leads to a lot more procedures. You end up getting medicalized, and some people have surgery. Welch says that women between the ages of 70 and 75 are more likely to be harmed, and that, quote, I know it's counterculture message, but I think it's the truth. And that goes to what I was saying at the beginning of this video clip, that it's considered heresy in some places to talk about mammography not being everybody knows it's the right thing to do. You have to have a mammogram. I've had women ask, well, what am I supposed to do if I don't have a mammogram? What you're supposed to do is take care of yourself. That's your best protection against breast cancer. It's not screening, all right? The take-home point I want to make here: population screening for cancer doesn't reduce the death rate from cancer, with the exception of Pap tests, which have significantly reduced the death rate from cervical cancer. But all the rest of the stuff, lung cancer screening, thyroid screening, skin cancer screening, there's not a single randomized trial that's ever shown that colonoscopy reduces your risk of dying of colon cancer. Everybody knows you should have a colonoscopy, but if you really start looking at the medical literature, which I don't understand why people aren't reading the medical literature, there is not a lot of evidence to support colonoscopy. There's a special recommendation to people age 70 and older. Much greater significance of a significant risk of harm. And it's for a couple of reasons. More likely to find abnormalities, and the treatment is just more harmful. The older you get, the less you can tolerate in terms of surgeries and radiation and drugs and all that sort of thing. So it'll probably be a while before you hear from me again on mammography, but I think every year I put out at least a couple of video clips about it, and prostate cancer screening and other screening tests too, because we're not helping people, we're hurting people. If somebody wants to have this test, I think it's okay to give it to them, but I think they should know this information before they say yes. All right, that's all for today. It's all for the week. As usual, pass this on to anybody who you think would enjoy watching it, and I'll be back to you next week with more news.